Good afternoon or morning to some of you. We'd like to welcome you to the CDC's recommendations for providing quality STD clinical services. And if you don't know, I'm Gail Bolan. I'm the Director of the Division of STD Prevention. So we realize we have limited time, so we really want to dig into this content of this webinar. So the webinar today is intended for providers of clinical care services of persons with or at risk for STDs in public and private healthcare settings. So these include STD specialty or sexual health clinics, primary care settings, HIV care settings, family planning, public health department clinics, community health centers, and health maintenance organizations. What this webinar is doing is we will be emphasizing the importance of STD clinical services and the role that they play in STD prevention. We really cannot control infections without having our patients correctly diagnosed and receive timely treatment. And it's going to give us an overview of the recommendations for providing these quality services. And at the end, we will be having a question and answer session. It's important in the interest of time that you submit questions as we go through the presentation in the chat box, indicating the slide and slide number and topic. And as always, these slides will be posted. This webinar is being recorded because we recognize a lot of our colleagues were not able to attend this session. So first, I'd just like to get a handle on who our audience is today. So we actually have two questions that we would like to ask of you. The first question is for those of you who work in a clinic setting, and the second question is for those of you who work in a public health setting or a non-clinical setting. So the first question is, if you work in a clinic setting, what is your primary role? Are you a medical director, a clinician, a clinic manager, a health educator, and that could include counselors. We're just using sort of some general topics here. A disease intervention specialist, a patient navigator, or some other type of provider. So are we ready to see the results? Okay. So it looks like the majority of people who work in a clinic setting are clinicians that are on the call. So thank you very much for that. So we'll move to the next poll. So the next poll is similar. If you work in a non-clinical setting, what is your primary role? Are you an STD program manager? Are you an HIV program manager? And for those of you who are both, we'd like to know what % time you spend on these two roles, and pick the one where you spend most of your time, either STD or HIV. Are you a disease intervention specialist? Are you a health educator? Do you work not directly with clients, but work in some level of a nonprofit organization? Or do you work in a government agency, not in the role as an STD program manager or HIV program manager? Or if none of these fit for you, please check other. So we are ready for the results. Okay, so it looks like the majority of those working in non-clinical settings are affiliated with a government agency. And one last poll is we generally are interested in knowing where your worksite location is. And we're just doing this by HHS regions. We certainly are going to be educating you about our national network of STD HIV prevention training centers. In the past, we were structured by HHS region. We're in the middle of renewing those cooperative agreements, and so at the moment we will be looking at the best distribution of those who are funded for when those new cooperative agreements start in April of this year. So basically, are you from Region 1, which is Connecticut. I'm not going to go through all the states here. You can look where you are. Region 2, Region 3, Region 4, Region 5, Region 6, Region 7, 8, 9, or 10. So we'll give you a minute. If you don't know which HHS region you're in, we'll give you a minute to figure that out. And let's see what the results are. Okay, so it looks like we've got all regions represented, and we've got a number from 3, 4, and 5 have higher percentages than our other regions. So thank you for that. So let me just start with, moving to the next slide, an overview of the state of STIs in the United States. Next slide. I think most of you are aware of our infographics and maybe participated in our surveillance report, so I just want to remind everyone that we've had a major resurgence of STIs in the last 5 years, and we are at the highest level ever of these cases that are reported to us. Next slide. We've got different increases occurring and different epidemics occurring in the United States. We are very concerned about the rise that we've seen among men, gay, bisexual, and other men who have sex with men. We've been looking at some ecologic reasons as to what the drivers and determinants of these increases could be. And obviously we know that since life-saving medications back in the early 2000s became available is when we really started seeing significant increases in syphilis among gay, bisexual, and other men who have sex with men. Next slide. We really did not start seeing any increases in heterosexual populations until about 2012, 2013, and certainly we're still exploring as to the reason of why then there seemed to be some bridging from the gay community to the heterosexual community. But what's concerning us now is with the rising rates we're seeing of women of reproductive age, we are seeing, again, unprecedented increases in our congenital syphilis cases. Next slide. We do, from our case information on women with syphilis, have identified that there's a number of drivers and determinants of our rising incidence of syphilis in women. We have our traditional risk factors, such as multiple sex partners. What's been interesting in sort of the epidemiology of congenital syphilis and women with syphilis is we're starting to see a lot more social determinants of health factors involved in the lives of these individuals. Look, things like we did not see back in the crack cocaine epidemic in the 90s. Certainly of the substance misuse we're hearing about, meth seems to be the most common, although there is some connection with the opioid epidemic. But we're also seeing significant number of cases related who are living with unstable housing. Actually, the women are giving us a history of incarceration, not just having a partner who was recently incarcerated. And we're also just seeing lots of women that have no prenatal care for a variety of reasons, so that we are challenged by many factors, underlying determinants and drivers of our congenital syphilis epidemic. The next slide, just quickly, again from our surveillance, is just looking at the drivers of syphilis in women, specifically by substance use. And I think what's most interesting of this, the percentages are relatively small on the scale, but we're seeing a significant increase of everything we're measuring at the moment at the national level, which is heroin use, meth use, and injection drug use. Significant increases among women, some increases among men who have sex with women. I guess the good news of the slide is that we have not seen a corresponding increase among substance use among men who have sex with men who have syphilis. Next slide. We also want to make sure that we're closing the gap in terms of the missed opportunities. Again, this is a quick overview, so I just want to let people know that nationally, based on data from 2017, we're in the process of updating these data. About 34% of women have either too late to do anything or no prenatal care at all, and were not screened or treated. We do know that we are missing people being screened at the beginning of their pregnancy. Not only are they not being screened, but we also find out that when they have a positive test, they're not getting timely treatment because many providers don't have benzathine penicillin available, and they get referred and sometimes lost to follow-up. And then we also know there's a lot of missed opportunity for women who are initially screened and negative, but were actually infected during pregnancy, which makes their fetus at an incredibly high risk of infection. And they're not getting that rescreen at 28 weeks. And again, obviously at delivery, we'd like to be identifying and treating before we get to that point, because usually at delivery you're going to have babies with congenital syphilis. There's a lot going on in the field of STD, next slide, where we have a lot of national strategies that are informing our priorities. And I just want to mention the ones on the bottom that you may not be familiar with, or maybe also in the middle row. We certainly are hearing a lot about ending the HIV epidemic, which the Division of STD is participating in because we believe that strengthening STD clinics are important to be contributing to ending the HIV epidemic. There's also been some reports. There was a NAPA report about sort of the state of STIs, and that we want you to be familiar with. And also that we're in the process of working on a NASEM report. This replaces the IOM, that's the National Academy of Science, Engineering, and Medicine. We expect that report out in 2021. And then we're very excited that the Health and Human Services Agency has prioritized STIs as having an action plan, and we expect that to be out in 2020. I'm going to skip the next slide. We have a plan for our division, but the point that I want to make on this slide, given the number of clinicians participating, is that basically, our main strategy to reduce this rising tide of infections in the United States is basically, rapid detection and timely treatment. And so we really can't do it without our STD specialty clinic providers as well as the primary care setting, because we also recognize now that the vast majority of STDs that are reported to us nationally are not seen in STD clinics anymore. They're seen more in the public setting. So as a result, next slide, we received some feedback at our last STD Treatment Guidelines meeting in 2015, where people said, well, this document's great. It's like got everything I need to know about how to manage my patient with STI, but I also happen to run a clinic, and I don't know what types of services should be available in my clinic. And so we felt that the guidance that had been put out by our family planning partners of providing quality family planning services would be a good document for us also to have in the field of STDs. And it's really important to recognize that this document that we're going to be talking about today is not how to manage your patient. That is the treatment guidelines, which we're also working hard on updating and are hoping to get out this year, our revised edition. But we wanted to have a document that's more of a policy document that actually says, if I'm a primary care provider, if I work in a primary care setting, what kinds of services do I need to have available if I'm serving people at risk for STIs. And then we also felt that STD specialty clinics have played a very important role in the history of STD control in this country, starting back with Thomas Perrin's Shadow on the Land. We know that there's been some major infrastructure erosion at the state and local level, which is where the support for STD clinics come from. A number of clinics have closed over the years. We think that some of our rising tide is because people can't get the same high-quality, comprehensive, same-day diagnosis and treatment that they had available to them in parts of our country, and especially urban areas in the past. So we also want to really make it clear of why STD clinics are important, but also if we're going to say they're important, we need to distinguish why they're different than a primary care setting. So that's why this document has two parts, sort of, if you're in the primary care setting, these are the services that we think need to be available in your clinic setting, and we know they're aspirational. And then if you're in an STD specialty clinic, we also are putting these documents out for you to refer to as tools, not rules, to consider for the patients that you serve to be considered sort of an STD specialty or sexual health clinic. So with that, I would like to move the discussion over to Dr. Roxanne Barrow. We are lucky to have her today because she is a Commissioned Corps, and we've just learned today that all Commissioned Corps are on notice to be deployed for working on the novel coronavirus. So we are lucky we got this webinar in time to have Roxanne here today. And lastly, I'd like to remind you, please put your questions into the chat box as we go. because right now I don't think we have any. All right, Roxanne, let me turn it over to you.
Okay, thank you, Dr. Bolan. Good day and welcome all. As an overview of the STD QCS recommendations, we'll cover the topics that you see outlined here. But first, we'll begin with the process for developing the recommendations, which include input from steering committee members, external work group members with expertise in STD care in primary and STD specialty settings. After the formative work from these committees and work groups, we held a consultation meeting to further discuss feedback. A Federal Advisory Committee, CHAC, which is the CDC HRSA Advisory Committee on HIV, viral hepatitis, and STD prevention and treatment, convened a special work group to review the recommendations and provide additional feedback. The CDC STD work group used all the input to formulate the STD QCS recommendations that were recently published. Next slide. There were three key questions that we addressed in the development of the recommendations. The first is, what STD-related clinical services should be available to persons who have or are at risk for STDs in primary care settings? And second, in STD specialty settings. And then third, what STD-related conditions should be managed through consultation with or referral to a specialist? Next slide. With these questions in mind, the main purpose of the recommendations is to highlight optimal services for providing quality STD care based on previously published guidelines. The recommendations complement the CDC 2015 STD Treatment Guidelines, and they do not replace them. The recommendations are not intended to develop new guidance for when or how to provide the services. They are also not intended to mandate or regulate services. And as Gail mentioned, these are recommendations and they're tools, not rules. It's not anticipated that healthcare settings will provide every service that we have outlined for quality STD care, and the converse is true, that every service available in healthcare settings will not be captured in the recommendations, and do not imply that those services are not quality services for that setting and that they should continue. The aim is for healthcare settings to use the recommendations as a tool to critically assess which services are available in their facility and as a way to build, maintain, or enhance the delivery of STD services as a policy document. Next slide. The recommendations are formatted by the strength of the recommendation. A strong recommendation is stated as should be available and implies that all or most all informed providers would choose the recommended course of action. A weaker recommendation is stated as could be available and indicates that most informed providers would choose the recommended course of action, but some would not. Next slide. In the recommendations, the level of services described as basic and specialized STD care. Basic STD care, at minimum, should encompass a sexual health assessment, screening, and treatment services. Specialized STD care is described as the delivery of timely, comprehensive, confidential, and culturally sensitive STD clinical services. It includes basic STD care with the capability to provide on-site immediate diagnosis and on-site injectable antimicrobials, such as the STAT syphilis test, gram stain and wet mounts, gonorrhea culture capacity, and benzathine penicillin and ceftriaxone. Next slide, please. In these recommendations, we describe what level of care may be available in clinical settings. Basic STD care is described as being provided in clinical settings where patients are evaluated for a variety of health conditions, such as in the primary care settings, which can include adolescent health, family planning, or federally qualified community health centers. Specialized STD care is described as being delivered in clinical settings that have a primary focus of providing STD care. That may include STD specialty settings such as STD or sexual health clinics. Of note, the level of care can vary by individual setting based on the clinical scope, and STD care in primary care settings might often offer some of the same services as STD specialized settings. Next slide. So now that we've gotten you a little familiar with the level of STD care, we're going to take another poll. And so we would like to know what level of STD care is provided in your healthcare setting, basic or specialized. And as a reminder, basic STD care at minimum should encompass the sexual health assessment, screening, and treatment services. And for STD specialized care, the delivery of timely, comprehensive, confidential, and culturally sensitive STD clinical services. Okay. All right. So we'll go ahead and close the poll. And it looks like we have very good representation from both settings, and so that's really great to see. So now we'll move on to talk a little bit more about what's in the recommendations. The recommendations are organized into 7 categories, and those STD-related conditions that should be in consultation with or referred to a specialist are listed separately. Next slide. So as we move on to review the recommendations, this graphic will help us keep in mind how the STD QCS complements the STD Treatment Guidelines. So the recommendations, the QCS recommendation is based on the STD Treatment Guidelines, and they outline what services should be available in clinical settings. While the STD Treatment Guidelines, they offer guidance on what services may be available for caring for an individual person who's receiving these STD services. So the STD QCS is focusing on the services in clinical settings, and the treatment guidelines is focusing on what clinical management should be done for an individual seeking STD services. So next I'll just walk us through some of the guidelines that we have here. I will not go through them in great detail. We're just giving you a high-level view today, but we'll point out some other recommendations that are similar for both the clinical settings and also what are different for the 2 clinical settings. Next slide. So we'll start with the patient assessment, the sexual history and physical examination. Next slide. So we'll move on to the next slide, and we'll show that in that top purple section on the page. Next slide, please. The services are the same for both primary and STD specialty settings, and those are highlighted in that red section. Next slide, please. In the blue section on your left, the services specific to primary care settings are listed. And in the green section on your right, the services that are unique to STD specialty settings are listed. Next slide, please. Also noted is the strength of the recommendation should be available, and that's in the purple text. And in the blue text, you see the could be available recommendations. Next slide, please. Also note there are recommendations that have been listed for just one clinical setting. So in this instance, you'll just see colposcopy should be available under the STD specialty care setting. Next slide, please. So we'll move on to the prevention and partner services. Next slide. The same thought applies to the recommendations for prevention services. There are several prevention recommendations for both settings up at the top, and at the bottom you'll see the specific services for each setting below. Next slide, please. And as we move on to partner services, The same services for both settings are up at the top, and one example is EPT, which should be available in both primary care and STD specialty settings. The specific services for each settings are at the bottom. For example, interactive counseling for partner notification could be available in the primary care setting and should be available in the STD specialty setting. Next slide. We're going to move on to STD screening and evaluation. Next slide. So screening for most of the key STDs and STD-related conditions should be available in both settings, and we see that at the top of the slide. And at the bottom, you'll see that screening for trichomoniasis should be available in primary care settings and should be available in the STD specialty care settings. Next slide, please. And as with the evaluation of STD-related conditions, all should be available in both settings. Next slide. For the laboratory tests, the recommendations are separated into two categories: at the time of the patient visit and at the clinical laboratory. In most cases, the recommendations are broad in an effort to accommodate for advances in new test technologies. Next slide. The laboratory tests listed here are those tests that should or could be available at the time of the patient visit. Since by our definition, specialized STD care should have on-site immediate diagnosis, so many of the tests for common STIs should be available on-site for STD specialty care settings. Next slide. This slide outlines the recommendations for laboratories that should be provided at a clinical laboratory. At the top of the slide are the laboratory tests that should be available by clinical laboratory for both settings. As an example, for setting-specific recommendations, specialized STD care settings should have gonorrhea culture and antimicrobial susceptibility testing available by the clinical laboratory. Next slide. We'll move on to treatments. The treatments are also separated into two categories: on-site availability by prescriptions. Next slide, please. Listed here are the treatments that should or could be available on-site. In keeping with the description of specialized STD care, they should have on-site treatments available, including injectable antimicrobials. Next slide, please. This slide shows the recommendations for treatments that should or could be available. For any any medication that is not available on-site, it should be available by prescription. So we've covered quite a bit, and this covers all of the recommendations within the document. Now we'll move on to the next section with 3 slides that cover the STD-related conditions that should be managed in consultation with or referred to a specialist. Next slide. So, for example, complex cases of gonorrhea, such as gonococcal ophthalmia in infants, or complex pelvic inflammatory disease. Next slide. Complex syphilis, such as ocular or otic syphilis, or complex herpes, such as neonatal herpes. Next slide, please. Or complex warts, or situations of sexual assault, such as STDs in children. All right, so I know we covered a lot of information in a short period of time, but based on what you've heard so far, we're going to ask this question first of the STD specialty care group, and then we'll ask the same for the primary care settings. So for the STD specialty care settings, to what extent does your facility or clinic currently provide services outlined in the recommendations for your facility type? Provides most of the recommended services, provides some of the recommended services, provides very few of the recommended services, provides none of the recommended services, and not applicable to my work. Okay, we'll let you poll in for a few more seconds. Okay, we'll end the poll and the results, and this is really good to see. The majority are already providing most of the services, and another good proportion are recommending most of these or many of these services. So thank you for that. And now we'll do the same poll for the primary care settings. So to what extent does your facility clinic currently provide services outlined in the recommendations for your facility type? And it's the same. You provide most, some, very few, or none of the recommendations, or it's not applicable to my work. Okay, we'll give it a few more seconds here. Okay, so we'll go ahead and close out the poll here. And that's good to see. Again, the majority, even in the primary care setting, are providing most of the recommended services. There's a significant proportion that this is not applicable to their work. Right? And then we do have about 20% that are providing some of the recommended services. So thank you for that, that information. All right. So now we're going to move on to next steps. The first is that we're working with NACCHO to develop tools and resources for implementing the recommendations. They are in the draft form and will be piloted first in several STD specialty clinical sites from February through April. And then we plan to launch these tools in July of 2020. And we'll have a webinar to launch that when that package is ready. So please stay tuned for that. We're also in the process of providing continuing educations for this document. So we saw that there are many clinicians that are on the call today that you'll be able to get your CE credits for reviewing the document. And then as Gail mentioned, we are also planning to have an update of the STI treatment guidelines, and hopefully we can have those launched later on this year. Okay, so before we move on to the question and answer session, I'd just like to remind everyone, if you do have any questions, if you would please send those through the chat box, and we'll get through as many of those questions as possible. But before we do that, I'd just like to share a few additional resources that we have available. Next slide. So here you see listed our main link to our CDC webpage. We also have resources such as the 2018 surveillance report. We have the current STD Treatment Guidelines, and those will be updated when the new treatment guidelines are available. We also have a link to the NNPTCs, which Gail explained. These are centers that assist clinicians in the United States with skills, knowledge, and experiences that they need to address and prevent STDs in their patients, and these centers are funded through us here at CDC. We currently have 8 regional centers assisting with clinicians in their training area, and 4 national centers working on special projects. Next slide. And you'll see the map of where these NNPTCs are located. Next slide. And here are just a few examples of some of the resources that they have available, such as a sexual history app. They also have a consultation line for clinicians that we really encourage folks to use. So I will end here, and we will move on to the question and answer section. And in doing so, I would like to introduce our panel members for the Q&A section. Next slide. First, we have Dr. Laura Bachman, and she's our Chief Medical Officer here in the Division of STD Prevention, and she also serves as the team lead for our clinical team. We also have Kim Workowski, and she's our lead author for the CDC STI Treatment Guidelines, and she also served as the co-author on this document as well. So with that, I will turn the session over to Dr. Gail Bolan, who will facilitate the Q&A session.
Okay, well, thank you all for participating in the chat, and we are still monitoring, so it's not too late to ask questions that may be coming to mind. We did have someone who was a little late and wanted to know how they would get to access the PowerPoint, and I said that we would be posting these slides on our website.
Yes.
Okay. I wasn't exactly sure where. And then there's a question that comes up often, and I'll start off with answering this question, and I'm going to defer all the other questions to our clinical experts, Dr. Bachman and Dr. Workowski. But one question is, this is a serious question, STD or STI? I hear Dr. Bolan using both. We've had a heated discussion about this at our state health department. This has been an ongoing discussion nationally. It's been going on for a number of years, and there's some very good literature that we can refer you to that was published in the STD Journal, sort of a commentary by Dr. Hunter Hansfield and Case Reitmeyer giving different perspectives of STI versus STD. This was debated among all our federal agencies in developing the HHS STI action plan. That process that is being used in the HHS action plan is somewhat of a consensus-based process, and everyone did their homework and read the articles, and it was decided that the HHS plan will be an STI, a sexually transmitted infection action plan. And actually, because it was such a debate, and we also know that family planning traditionally uses the term STI, and WHO traditionally uses the term STI. But I believe the federal action plan will actually be clarifying the difference between an STI and an STD, because as most of you should know, the term sexually transmitted infection refers to either a virus, bacteria, fungus, or parasite that has infected a person's body by a sexual contact, where the term sexually transmitted disease refers to a recognizable disease state that has developed from a sexually transmitted infection. So obviously these terms are used somewhat interchangeably, but generally I believe that most people feel that the term, STI, if we could eliminate all the infections, we wouldn't have any disease. Using the term STI your goal is to prevent and treat infections before they develop into a disease state. However, the term STD is used when referring to data or information from sources that are focused on STD, disease prevention. I will say that we have had this debate for the treatment guidelines because they have been STD treatment guidelines, and we've renewed the debate within our division. And basically, you will be seeing that it's been decided that the 2020, formerly known as STD Treatment Guidelines, will become the 2020 Sexually Transmitted Infection Guidelines. But within our division, we felt with the level of resources that we have, and given we work for a disease control agency, we are not changing our division title. We are going to remain the Division of STD Prevention. So that is the debate, and we look forward to hearing from those of you who are going to be using STI and those of you who are going to be using STD. We do have, obviously, the National STD Association is still using STD, and I don't know if they've been having debates about whether they should change to STI. So that's a wrap on the serious question of STI or STD. So the next question I'd like to pose to Laura is there's a lot of questions about, how do you define a sexual health clinic as opposed to a family planning clinic? So what's the distinction between a sexual health clinic and a family planning clinic?
So this is Laura Bachman. The definition of a sexual health clinic has been kind of a work in progress, but I think the overarching theme here is that when we talk about a sexual health clinic, we're talking about a clinic that focuses on all aspects of sexual health. It's comprehensive. This is a clinic that serves males, females, everyone. It's culturally sensitive and has, besides the basic STD care, at the very least, same-day diagnostic and treatment services, and in particular, syphilis testing available, gram stain, wet mounts, or I guess you could have methylene blue or gram stain, wet mount, the availability of gonococcal cultures, and then on-site benzathine, penicillin, and ceftriaxone. So that has been our working definition, and I think where this document is going in terms of making the distinction between basic STD care and specialized STD care, where the focus is on the sexual health.
Okay. The next question comes, we have a number of clinical questions here that people are looking for feedback on. So the big question about the difference between specialized versus, basic, came up a number of times, and Laura's just answered that. So let me go to some of the clinical questions. So, Kim, this question comes up a lot. After you treat someone for chlamydia, how soon should the full STI testing be done, 30 days or 3 months?
So there are no recommendations for a test of cure for patients with chlamydia, except in instances of pregnancy where the recommendation is to retest 3 to 4 weeks because there can be dead nucleic acid that's detected in the test. So there's a distinction between test of cure and retest. So if the question is meant to be a retest, the reason for the retest is in instances of chlamydia, gonorrhea, and trichomonas, because there is a high incidence of reinfection after these infections. So the recommendation for retesting is 3 months.
Okay, now there's a question about what's the status of the rapid syphilis testing at the clinic level. As you know, there's one test on the market. We think there's going to be more soon in the United States, FDA-cleared tests. We've been told that the current tests are not very accurate, not as sensitive nor selective as needed to be reliable. Is there any particular test product you recommend? The challenge is that after rapid HIV testing, patients do not want the syphilis test because it's a blood draw that it's sent out. So I don't know, Kim or Laura, if you have any comments.
So syphilis diagnostics are a challenge. We know that, and taking care of patients in the clinical situation, as we don't have a good point of care test. As Gail mentioned, the rapid tests are treponemal tests, the currently FDA-cleared test, and so it will not be helpful in situations where a person has had a previous infection with syphilis. Where it may be helpful is in somebody that's not had syphilis before, because those tests do tend to be a little bit more sensitive and picking up primary infection than an RPR, or in instances where you're concerned about primary syphilis, whereas that RPR may take several weeks to become positive. So we recognize that is an issue, If you are concerned about that, as what's mentioned in the treatment guidelines, that you've got somebody with probable primary disease, is number one, you order an RPR and a treponemal test together, because the treponemal test that you get will pick up more of the primary infection, especially if it's a primary infection, and that if you're concerned about syphilis in view of the epidemic, you treat. If that RPR comes back negative, then you have the patient come back in 2 to 3 weeks and repeat the RPR. But if you're concerned about that, if you order the 2 tests together, getting the RPR and the treponemal test instead of relying on a rapid treponemal test that has problems with test sensitivity and specificity.
Okay. And one last, and then we're around clinical. We've got more coming in, so I'm going to do some health department questions. On slide 39, thank you for following our directions, a suggestion was made for trick testing in clinics. And this person already tests for females. Are we suggesting testing for males on demand? So it's really, again, we want the tests available, and the treatment guidelines tell us who should be tested. Kim, do you want to comment on that anymore?
Yeah, so basically that's could be available for the basic setting, and it should be available in the specialized setting. And basically the recommendations are for trichomonas for women with vaginal discharge that are symptomatic. It is recommended that that test be done. There are, in the STD treatment guidelines, there are recommendations for women at higher risk for trichomonas that in your particular setting you can consider using the test in that setting. There are no recommendations for use of the test in males per the STD treatment guidelines. The other thing to mention is trichomonas is very uncommon in men who have sex with men. And should only, if you do the testing for whatever reason, it should only be done in heterosexual men. Some of the tests, however, that's commercially available is not FDA cleared for use in men. So the recommendations to use the test is based on women and based on whether they're symptomatic or asymptomatic.
Okay. We have an easy question. Any change in the guidelines for reporting to state health departments?
No.
Okay. The answer is no. We're making no changes in reporting requirements. And as I think most of you know, it's always good to be reminded that all reporting requirements are done at the state and local level. We at CDC serve at the pleasure through CSTE to have data submitted to us. So we encourage all providers to be knowledgeable about what your reporting laws are in your state, because they do vary quite a bit. There was another question about a lot of health departments have integrated family planning and STD services. Basically, you know, STD screening services are clearly an integral part of family planning services. The question is, how would we assess the implementation of these guidelines in these kind of integrated clinical settings? And there's also a question about a lot of health departments have sort of general, you know, health clinics, and how would we be implementing these guidelines sort of in a general health department, you know, clinic setting. So and obviously we say these are tools, not rules, and we're going to be assessing and seeing how implementation goes. But Laura, do you want to talk a little bit about that?
Sure. So in order to assist different settings with really operationalizing these recommendations, there is a tool that is currently under development right now with our partner NACHO, and CDC is working with NACHO and other partners to develop a tool give to aid clinic administrators, clinicians, et cetera, in assessing services that are currently available in your setting, comparing them to what would be recommended in these guidelines, and then making leads you through the determination of what should you add, or maybe there is a reason not to add recommended tests. So the goal is for this tool to be practical and to facilitate that. We're anticipating the launch for the user package just tentatively in July of 2020. Around the time, hopefully shortly thereafter, we'll have some treatment guidelines out there for you as well. But just keep your eyes peeled for that. That is to help just operationalize these recommendations.
Okay. I can see with the number of clinical questions that we're getting here, we are going to need to have another webinar to get through all these questions. Certainly, we'd be happy to do something before the treatment guidelines are released. So in case we don't get to your questions because we are completely overwhelmed, we will make sure that these have been great because they're very helpful to us of sort of our, this is almost becoming a needs assessment here at CDC.
Mm-hmm.
There was a couple interesting questions here, and I'll ask Kim to answer this one, that basically the MMWR states that cephalosporin or IgE-mediated penicillin allergy is a reason to refer to a specialist for complex chlamydia questions. That might be complex gonorrhea questions. Why is this? Why can not a complex allergy?
So I think part of the difficulty that clinicians have is assessing whether something is an IgA-mediated response. And whenever, in my experience, whenever colleagues see a penicillin allergy, they want to go to the next step without delving into the history of the penicillin allergy. So the issue is really truly an anaphylactic reaction is what we're looking for in terms of referral. Basic questions to be asked about when the reaction occurred, at what age it occurred, did it occur immediately, did it occur 10 days later, what was the exact reaction. Most of the times that taking a history, a more extensive history, will make one more comfortable with this penicillin allergy that occurred, and usually in most instances there's not a problem on further testing. One of the concerns that comes up, though, however, is the use of cephalosporins in somebody with a penicillin allergy. So the use there really comes down to taking an adequate history, looking for other medicines that they may have had taken orally, such as oral cephalosporins, such as Keflex, and other oral cephalosporins, and if they're well tolerated, the cephalosporins are fine to administer. So what we're really looking for, and that is really described in depth in the STD Treatment Guidelines, is an IgE-mediated reaction that clinicians feel uncomfortable either administering penicillin or a cephalosporin. More of the details on that is going to be in the STD Treatment Guidelines for immediate. If you have immediate questions, that's referenced. There's a special section in the 2015 guidelines regarding allergies, penicillin, and cross-reactivity with cephalosporins.
Okay. Another question sort of about medication and sort of what we mean. So one question is, what do you mean available on site versus by prescription? And then does CDC recommend empirical treatment if a patient has symptoms or only after a positive result? So first let's take the question about what do we mean by on-site versus prescription.
So, I mean, on-site would be available for dosing on-site, so able to give that injection while the patient's there in the clinic, or dose them with, say, azithromycin while they're in the clinic, versus prescription would be sending them out the door with a prescription for those medications. And what was the other one?
The question is about, do we recommend empiric treatment if a patient is symptomatic, or only treatment after a positive result?
So I think I'm going to take that into saying, we'll talk about genital ulcer disease, and then we'll talk about a discharge presentation. So for genital ulcer disease, we already kind of mentioned the issue with a presumed genital ulcer. We unfortunately don't have a point of care test that we have available to us, and STDs can look sometimes very similar. We can have multiple STDs at the same time, and in the presence of immunocompromise, there can be alterations in the clinical presentation. So the recommendations that, per the treatment guidelines, there's a specific section on management of genital ulcer disease and management of discharge. So for genital ulcer disease, most infectious genital ulcers are due to syphilis and genital herpes. There are recommendations to do diagnostic tests. If you don't know, in particular what we just mentioned before about syphilis, you get the appropriate test and you treat appropriately that day, either immediately if you don't have benzathine penicillin on site. You get on the phone and you find out where they can have the penicillin done that day. So that's really important, especially with the epidemic of syphilis that we're having. It's not waiting 3 weeks to get treatment. It's same-day treatment. For a discharge presentation, the recommendations are to perform diagnostic tests and in the presence of symptoms to treat for if you've got chlamydia, if you've got urethritis and cervicitis, there'll be recommendations which test to order in the new treatment guidelines, but you're going to be treated both for chlamydia and gonorrhea after you send the test results back. The test results are important both for epidemiology and for partner services.
And I would just like to add, because it's another question here, is what's considered timely detection and timely treatment? Is there actually a time frame to attempt to achieve? And we in public health tend to overtreat our individuals for the health of the community. So when contacts come in, it's been standard of care that you automatically treat that partner. You do not wait for test results to come back. And the general rule is we do not want people with infections running around and spreading disease while we're waiting for test results to come back. And some states even have laws that if you actually do not manage your patient at the time of presentation, you can be held liable for any other people that get infections or complications like PID if you didn't empirically treat the individual. So that's the reason why STD specialty clinics are so clear. We cannot have people coming back and being given appointments to be seen and then waiting for test results. There's too much disease spreading in the interim. So the definition of timely detection and treatment is as soon as you have the opportunity to test a patient or screen a patient, that is timely detection. As soon as you have the opportunity to take care of the patient in an STD clinic, that should be same test, same treatment, same day, no waiting for appointments. So it's, we don't have time frames, but we have had some time frames in the past with our IPP program that we wanted people who were screened for STDs that they're treated within 14 days of the diagnostic test being done. So that's a measure that we've had in the past for timely treatment for the asymptomatic individual that doesn't know. Obviously, you're not going to empirically treat them. We have 1 minute left, and we have not gotten through many of our questions. I'm just going to pick one that...
I just wanted to also follow up, Gail. This is an important question that was posed. It was related to your answer, but there was a question about in those areas where you have a larger population of women who lack prenatal care, they come into the local health department for pregnancy testing. Do we recommend that they have chlamydia, gonorrhea testing and also syphilis testing in those clients? And I felt like that was important to address given the data that you just showed earlier about our unprecedented number of cases of congenital syphilis. And that is really for women who are pregnant or planning pregnancy. It's just very critical that we take the opportunities that we have to perform screening when we've got them in front of us, since many do not actually access formal prenatal care.
Right. I completely agree with that, and I think that our guidelines in the past have alluded to the fact if they may be, someone who you're concerned about follow-up, at all, who comes in for a pregnancy test, you should test for syphilis especially at the time, because you may not be doing, although now we have, capabilities to do chlamydia and gonorrhea, because you don't need a provider to do the exam. So yes, I think that if you've got concerns about any kind of follow-up, people should be tested at the time of the pregnancy visit. And I do know there's some people in the family planning world that are actually evaluating the yield of that type of approach, like just bundling the STD testing with when they come in for pregnancy testing. And we certainly encourage that. We need more data in the field to help guide us on how we need to design our most cost-effective interventions. So I think, unfortunately, with that, I will not answer the very interesting question about why Hep A. It was not recommended for primary care clinics. We had a huge debate about that. The pediatricians all have hepatitis A in their clinics, partly because of the utilization and the challenges of having to buy the vaccine up front, keep it refrigerated. Docs are very concerned about the fiscal burden of having vaccination in their clinics, and at the time it was felt that in all primary care clinics it would be difficult to do that. Could, not a should. So we will collate all these questions and make a plan and get back to all of you. We really appreciate all of you. We've got quite a number of people on the call who have really important questions. We will not miss any. We may be able to develop some frequently asked questions to get out via email, and then have more of an interactive webinar for some other questions. So again, I really want to thank Roxanne Barrow, Dr. Barrow. She has been working on this effort for many years. Even before we started with the new approach and stop it, we decided not to define clinics by brick and mortar. We wanted to define clinics by services provided. And she's done a yeoman work, and it's had a long labor and birthing process, but we're excited. We recognize it's just a start. We want your feedback. If you have concerns about these guidelines at all, please let Dr. Bachman know. And we will be evaluating and here to support. We got questions about low resource areas. How can they be sort of raising the bar of the services that they offer? So we recognize, as with anything, it's a continuum of where people are in terms of the services that they provide and the services that they want to provide. And we're here to help ensure that any patient or any person in this country who's vulnerable for STI acquisition, gets the quality care that they deserve when they come into any kind of clinical setting. So thank you very much, and thank you, Kim and Laura, and we will be in touch.